Slide. We're taking a bit of a cross-Canada approach today in terms of the delivery of this webinar. The first portion of the webinar will be delivered by my CADTH colleagues from Ottawa. We will start with Gino De Angelis, Clinical Research Manager with CADTH, who will discuss the clinical effectiveness and cost considerations of home-based dialysis treatments as they compare to traditional in-center hemodialysis. Next, Tamara Radar, Patient Engagement Officer with CADTH, will discuss patient and caregiver experiences and perspectives on dialysis treatment. Next, Effie Healis, Knowledge Mobilization Officer with CADTH, will discuss common implementation issues for home-based dialysis and considerations for special groups of patients. All of this information is based on the results of the CADTH report. Finally, we will travel back to Saskatchewan, where Carmen Berglund, nurse clinician in the Kidney Health Community Program, will discuss dialysis services in Saskatchewan. Please feel free to type any questions you may have into the chat box, and we will answer them during and at the end of the webinar. For follow-up to the webinar, do not hesitate to contact myself or the CADTH team for more information. And contact information will be available at the end of the webinar. With that, I will pass it back to Ottawa and Gino to discuss the clinical and economic findings.
All right, hi everyone. So as was mentioned, my name is Gino De Angelis. I'm a clinical research manager here at CADTH, and I'm going to be discussing findings from our clinical review as well as our economic evaluation. So again, all of these findings are based on our report, our often used report, which was recently posted on our CADTH website and can be found at the link here. Before I begin, I just want to acknowledge our large project team. Quite a few people were involved in the project. The clinical review was led by Dr. Alison Sinclair here at CADTH. Our economic review was led by Dr. Scott Clarenbach at the University of Alberta. Our patient experiences and perspectives review was led by Tamara here, who will be speaking. Our ethics review by Dr. Daryl Coleman at Memorial University. And then our implementation review, which was led by Effie and Kristen here at CADTH. So some main issues and how this project came to fruition. It was a proactive topic that was identified internally here at CADTH, and it's based on the ongoing and widespread interest in dialysis alternatives to in-center hemodialysis. So of course we know about the high cost of dialysis in Canada. Based on figures in 2013, there were over 24,000 dialysis patients, and that led to an estimated cost of $1.3 billion, and that's direct costs into end-stage kidney disease, and those are based off figures in 2000. So most patients here in Canada receive in-center hemodialysis, which is the most costly modality, and dialysis alternatives to in-center hemodialysis may be as clinically effective and less costly. So this is how this project came to fruition. So with that, we conducted a health technology assessment, and the purpose was to inform policy questions regarding the optimal treatment for eligible patients and effective methods of implementation support for the various dialysis options for the treatment of end-stage disease. So our health technology assessment composed of various sections. So we did an assessment of clinical effectiveness. We then did an assessment of cost effectiveness. We looked at patient experiences and perspectives. We did an analysis of ethical issues, and that was followed by an analysis of implementation issues. So with that, we were left with two policy questions. And so the first one was to identify the optimal use, including patient selection and methods of implementation of self-care or assisted home dialysis and self-care in-center HD. And the second question was to identify what strategies could effectively be used to enhance implementation of self-care or assisted home dialysis and self-care in-center HD amongst eligible patients. So here's a framework that kind of illustrates the entire project as a whole. the population that we were interested in were end-stage kidney disease patients who require dialysis. You'll see the interventions that we were interested in were both hemodialysis and peritoneal dialysis, and we were interested in both levels of care, so assisted in self-care, as well as the home environment versus the in-center environment. And then in terms of outcomes, obviously our ultimate outcome was mortality, but we looked at some intermediate outcomes, such as technique failure, hospitalization, adherence to the dialysis regimen. We're interested in all types of harms data. We want to learn about the cost effectiveness and then the ethical issues and patient experience and perspectives as well. So again, this kind of sums up the population, the interventions, and the outcomes that we were interested in. So tying this back to our clinical review, we had 4 clinical research questions. The first one was, what is the clinical effectiveness and safety of home HD or PD compared with in-center HD? The second was, what is the clinical effectiveness and safety of home HD compared with PD? The third one was to identify the comparative clinical effectiveness and safety of home HD modalities, so nocturnal, short daily, and conventional. And lastly, what is the clinical effectiveness and safety of self-care in-center HD compared with traditional in-center HD? So we conducted a literature search, and we yielded quite a number of citations. You'll see that we came up with 7,000 citations here. And then we were left pondering and thinking what to do with all this literature. So essentially, we wanted to ensure that all the studies met our inclusion criteria, and then our investigators were left with categorizing these studies based on our research questions that I just identified. So back to question 1, which was home hemodialysis or peritoneal dialysis versus in-center HD. And we came up with 5 included systematic reviews and 3 primary studies. These studies were published in 2015 and 16. For the comparison of PD versus in-center HD, we had 6 included systematic reviews and 25 primary studies. And essentially what the data told us was that HHD, so home hemodialysis, may offer potential survival benefit, but it doesn't differ with any of our secondary outcomes, so hospitalization and our safety outcomes as well. It also told us that older patients may benefit less from home hemodialysis, and patients with diabetes and other comorbidities have similar survival compared with in-center HD. For our PD versus in-center HD comparison, again, there was no difference in survival for PD versus in-center HD, and especially when we looked at those studies that were in the Canadian setting. So our take-home from this question was that, again, there was home-based modalities appear to offer clinical benefits similar to those offered by in-center HD, and there were no consistent differences in patient health-related quality of life outcomes identified between the comparisons. On to our second research question, which compared home hemodialysis versus PD. We had 2 included systematic reviews and 6 primary studies. What the evidence told us was that patients receiving home hemodialysis had at least as good as, and in some studies, better survival than those receiving PD. There was no difference in hospitalization, and it also told us that home hemodialysis patients were more likely to undergo a modality switch. So again, the take-home from this was that it was unknown whether there's a difference in quality of life for patients who are on home hemodialysis versus PD, and home hemodialysis may offer a potential survival benefit compared with PD. But again, this is all based on limited evidence. On to our third question, which compared the home hemodialysis modality. There were no systematic reviews that actually addressed this question. However, there were 6 articles, so 1 RCT and 2 non-randomized studies which addressed this specific question. And what it told us was that there really was insufficient evidence to determine if there was any differences between these prescriptions at home. And lastly, for our 4th research question, so this was comparing self-care versus assisted care in terms of in-center hemodialysis. And again, there was no evidence that was found at all, so we didn't find any systematic reviews or primary studies that addressed this research question. So with all that said, we did want to note some limitations to the evidence. First off, most of the studies were not randomized. We also want to point out that a lot of these studies included a very selective patient population. So these were patients who were selected based on their types of dialysis, according to their clinical conditions, their preferences, and all these factors can influence outcomes. And lastly, a lot of these studies may not have been large enough to detect clinically meaningful differences. So I think there were only 3 RCTs, and these patient populations were less than 100. So again, not very large studies. So the bottom line for our clinical review is that overall, home-based modalities appear to offer clinical benefits that are similar to those of in-center hemodialysis. There were no consistent differences in patient health-related quality of life outcomes between home hemodialysis and in-center hemodialysis, or between PD and in-center hemodialysis. And there's no clear evidence of a survival benefit with any specific dialysis modality. With that, I'd like to move on to a very brief summary of our economic evaluation. So for this, we conducted a review of the literature to identify numerous economic evaluations and costing studies in Canada. However, most of them did not consider all the modalities and prescriptions of interest for this review. Our researchers then conducted an economic model, so this was a Markov model, to assess the lifetime incremental cost effectiveness of alternate dialysis modalities and prescriptions in patients with end-stage kidney disease in Canada. They did consider the location and the level of assistance, so self-care versus assisted. And we also took in consideration the geographical setting, so looking at the urban, remote, and rural settings. So based on the evidence from the clinical review, the researchers assumed that there was no clinical difference between modalities, and the cost-effectiveness analysis indicates that from a Canadian healthcare payer, so that's the health system perspective, that home-based therapies are less costly than in-center hemodialysis for eligible patients. And with that, conventional home hemodialysis appear to be the least costly. Assisted PD delivered continuously may be more costly than in-center HD and all other home-based modalities. And short-term assisted PD or intermittent assisted PD may be less costly than in-center HD. So the bottom line for the economic evaluation, again, was that home-based therapies, including PD, and all home-based HD modalities are less costly than in-center HD, with conventional HHD being the least costly from the health system's perspective. And with that, I'll pass it over to Tamara.
Thanks, Gino. I'm Tamara Rader, and that's me. I put my picture on there for you guys. And also, I'm presenting this on behalf of my co-author, Kristen Moulton. So our research question is really concerned with the experiences and perspectives of adults with end-stage kidney disease, and also their family members and caregivers. So I'm going to sort of let the cat out of the bag and give you the key messages right at the start, and then I'll explain how we came to these. So the key messages and our key findings are really that people prefer to have the option to choose the timing and location of their dialysis treatment. They hold a positive view about patient education, and they feel it's important to involve and share information with family and caregivers when it comes to decision making. So those are our key messages, and then I'm going to explain the 4 findings that led to those key messages. So for this section, we found that it was quite a well-studied area. So there were 788 citations. About 340 of those full-text articles were relevant. In the end, 6 systematic reviews and 211 primary studies fit our question and were eligible for inclusion in the review. So because we had so many systematic reviews that already answered our question, and were relevant to our policy question, we decided to do a review of these 6 systematic reviews. So the 6 systematic reviews, they came from all over the world. They included 65 unique studies, unique primary studies, and the population ranged in the number of patients that were studied and also the number of caregivers. So after this review, these are the findings that led to our key messages. Patients with end-stage kidney disease usually have been suffering from their chronic illness for a period of months or years. And by the time they're considering dialysis treatment, they're in poor health. And often their caregivers have been under strain for some time. To patients, we found that initiating dialysis treatment or changing modalities often represented a worsening of their condition, and it represents an increasingly invasive treatment. Patients understand that dialysis will not cure their disease and that choosing a dialysis modality is not choosing to get better necessarily. In spite of this position they find themselves in, it's clear that choice is important to patients. Freedom is important. They desire control over the place and timing of their treatment, and choosing a modality that optimizes freedom over their day-to-day activities. It was also found that for each patient, freedom might mean something different, depending on their situation. One finding that we came across was that caregiver burden can be overwhelming, guilt-inducing, difficult, and stressful. Non-professional caregivers and family members of the dialysis patient need to be prepared for that. Caregivers need support and respite. The other finding was that patients hold a positive view of patient education. I'm going to share some quotations from patients in a minute, and you'll see the kinds of questions that they have in their mind. Patients report feeling more empowered to make choices and more comfortable with their treatment when they have the information about all the treatment options and what to expect. The content, timing, and source of patient information was found to be important also. Opinions of family members and friends are important, so it may be worthwhile to have consistent messages directed at more than just the patient, at the family as well. The healthcare provider, the nurse-patient relationship is important in decision-making, but decisions do go beyond that relationship. So it's important to ask patients who else is helping them make decisions about their dialysis. So now I'm just going to go over these 4 findings that I just explained in detail, and I'll present some examples of some quotations from patients that sort of highlight how we came to these findings. It's not necessarily representative of patients, but what I hope to do here is so you can see the range of perspectives and experiences that we found. So in the first finding, control over place and timing, a patient said, that they felt freer staying home where they live instead of an environment where they see other sick people. And conversely, another patient said with chemo treatment in-center, they were much more comfortable with not having to take care of themselves at home, but to have this finite, discrete time when they went to the center. For the next finding, caregiver stress and burden. A caregiver reported, I had a meltdown. I got to the point where I didn't think I could go on. Another family said, very few people visit. Not everyone can deal with it. And in this case, I think that they were talking about just the state of health of their family member and also the equipment and the supplies that go along with having at-home dialysis. Depending on someone's living situation, it could really overwhelm your living space. So that was in relation to that setting. And finally, my mother is petrified. I said I will only do it on the condition that she is not a co-dialyzer. I wouldn't want her to have any responsibility if something was to go wrong. So although that perspective comes from the patient, you can see that the caregiver has a lot of stress. The next finding is really about desire for education and information. So I'm going to share some of these questions that were expressed by the patients. In one case, the person said, I can't look at my kidney, I can't put it in my hand and examine it myself. Why do I have to be on dialysis? What is kidney disease? So these are very basic questions about their condition that sort of need to be addressed before they choose modalities. In the next case, it was the ability of the patient to receive the information that came out. So the doctor, this person said, oh, the doctor might have mentioned it, CAPD, but I was so sick at the time I didn't catch on to it. So this idea that a person has to be in the right emotional state, physical state to optimize that education. Some other questions that someone expressed: what are the medications, the side effects? How do they know when the disease is reaching the end? That was the question. And finally, the last finding talked about including the family members and the trust that patients have in their healthcare providers. So in this case, the influence of others in making decisions. In this case, the man said he wanted to do home dialysis, but the wife refused. So I came to dialysis because I thought I could handle that. The next person, I know we couldn't do CAPD. No, I'd sooner trust the girls, and she was talking about the nurses here, because they're supposed to know about it. So this feeling that she had, she felt reassured going in center. And finally, this quotation, the doctors pretty much made the decision and my son agreed, which if you read between the lines, perhaps that patient, you know, really went along with the influence of others when it came to making the decision. So I've shared what we found in our review, but we did notice some gaps in the literature, and we also identified some implications for programs and policymaking. We didn't find much information about religion, sexuality, socioeconomic factors, which might be important when we're talking about people having this treatment at home, and also cultural factors. So we don't really know too much about that, of those subgroups. We did find that one size does not fit all. So patients consistently say they want freedom, they want control, but for some people freedom might mean being in center, and others freedom might mean being at home. And finally, findings about the caregiver burden have implications in jurisdictions which don't have support for informal caregivers or family caregivers. And the program might work better if that was addressed. So just to reiterate the key messages again, those findings really led us to distill our messages down to the importance of having the option to choose the timing and location of dialysis treatment, holding a positive view about patient education, and also the importance of involving family members and caregivers when it comes to decision making, since they seem to have quite a great influence in that part of it. And finally, for our bottom line, preference for any specific modality, home-based or in-center, may vary according to individual circumstances. Patients want to be informed about all available options and want their treatment conditions to be least disruptive to their lives and their day-to-day activities, as well as to their caregiver lives. Thank you. I'll pass it on to Effie now.
Thanks, Tamara. Hello, everyone. This is Effie Hellis, and I'm the Knowledge Mobilization Officer for the project. So for the next few minutes, I'm hoping that I can provide an overview of issues that we identified in our review as they relate to the implementation of home-based dialysis. So in addition to the clinical and economic reviews, as well as the patient experiences and perspectives that we just saw, CADTH also reviewed evidence and gathered information on issues that relate to dialysis implementation in Canada, trying to identify strategies that could be effectively used to improve the uptake of home-based dialysis. To address this issue, our research questions focus on identifying current strategies that are being used by various dialysis programs across Canada, and also on identifying barriers and facilitators that contribute to the implementation of home-based dialysis for eligible patients. To gather this information, we conducted an environmental scan. So in other words, we tried to reach dialysis program professionals, including nephrologists, dialysis unit managers and coordinators, as well as nurses, and we supplemented that information with relevant data from the literature from studies that reported on implementation issues for dialysis in Canada. And we supplemented this review with additional information provided to us by clinical experts in the field. At this point, I just wanted to make a parenthesis and say that the information in detail based on the environmental scan can be found on our project page at cadth.ca/dialysis. But for today's presentation, I will just quickly review the main implementation themes that came up from this process. So what we learned. Some of the things that came up in terms of strategies that are being currently used in Canada include provincial initiatives that take a centralized and provincial approach to funding and supporting home therapies. Also, groups that implement home dialysis have dedicated human resources in place specifically for home dialysis. We also heard that some groups are in the process of exploring the PD-first approach, while others mentioned that their mentality in their clinic is home first. Another strategy that was reported in our survey was having patients getting used to self-dialysis under nurse supervision, which then facilitates the transition to home hemodialysis. And similarly, assisted PD may facilitate transition to self-care PD. Finally, we heard about standardization of practices for home dialysis nurses, as well as having specific targets for training patients to be on home-based dialysis. The following two slides list the main themes that came up in our review regarding barriers and facilitators to home dialysis at various levels of implementation and decision-making. And for this presentation today, we will mainly focus on the reported facilitators that seem to support the implementation of home-based modalities. So at the healthcare provider level, we could be looking at education for clinical staff to improve knowledge and comfort with this type of treatment. At the health organization level, facilitators could include administration buy-in, researching other successful models and sharing information, and providing education for clinical staff as well as patients and caregivers to support patient choice. At the policy level, having policies that require the availability of patient education about these modalities, as well as policies about reviewing all patients for home therapy eligibility, was reported as a facilitator for home dialysis programs. Finally, when we're looking at the patient level, some of the facilitators that were reported included education, treatment decision aids, and also being able to connect with other patients who have had experience with home dialysis. Similar responses were received from nephrologists in our survey. Nephrologists supported patient education and decisional support, and they were also quite supportive for for policies of mandatory modality education and funding for formal caregivers, in other words, nurses, to provide treatment support at home. Funding for utility costs related to home treatment, such as electricity and water, was also highly supported by these respondents. We also reviewed implementation considerations for patients in rural and remote settings for whom we know these types of therapies may be most relevant as these patients have limited access to urban treatment centers. We only received limited information from the surveys about specific programs for these populations, and similarly only limited literature was identified for dialysis implementation in these settings. However, as you probably know, challenges to keep in mind include water quality, weather conditions, poor road access for home delivery of supplies, housing conditions, and lack of available emergency medical care. On the other hand, reported or identified facilitators to support home-based dialysis in these settings include comprehensive initial training for patients and caregivers, well-established plans for medical evaluation and emergency care, storage of supplies in secure and well-heated and insulated locations, nephrology support over the telephone, and in this case, telehealth may play a very important role in facilitating implementation of home dialysis, scheduled home visits, and availability of technical support. So in summary, from this analysis of the information, we learned that the availability of home-based and independent treatment options in Canada is not uniform. And in addition to a need for a cultural shift in dialysis care, infrastructure requirements to support home-based dialysis that also vary across the country need to be in place so that patient choice is supported. And by infrastructure, we mean physical infrastructure, funding, and education for policymakers, nephrologists, nurses, patients, and caregivers. But having said that, we also know that many professionals involved in dialysis care in Canada are committed to the promotion of home-based and self-care modalities for eligible patients. So based on all the evidence that we just reviewed, the recommendations that our expert committee formulated support self-care home-based dialysis, either with home hemodialysis or peritoneal dialysis for eligible patients diagnosed with end-stage kidney disease. But what does that mean for supporting implementation of home-based dialysis? Our review identified two main overarching strategies that can be used to improve implementation of home dialysis among eligible patients. First, by facilitating education to address existing knowledge gaps at various levels of healthcare decision-making. And secondly, by facilitating the sharing of successful strategies that are already underway in Canada. So with these aspects in mind, CADTH has already started disseminating this information and establishing collaborations for exchanging information between various groups in Canada. This webinar today is only one of a number of activities to come in the near future. For example, in the fall, we are planning a national event that will include and engage stakeholders from various provinces and parts of the continuum of dialysis care. More targeted events and more specific tools are also being planned to support context-specific implementation in various jurisdictions in Canada according to specific local needs. For now, a number of summary tools of the main health technology assessment report as well as articles are available for use. For example, we have two summary tools that provide the main points and key messages of the report. Also, you can find information about our results and home-based dialysis in general in two articles, one published in Healthy Debate and the other one which is available in the current issue of Hospital News. Another way that we can facilitate exchange of information is by brokering existing information, such as this list of decision aids and other educational materials for dialysis professionals and patients. And this list is available on the Canadian Kidney Knowledge Translation and Generation Network website. And at this point, I would just like to say that some of the tools and information that I just mentioned is already available on the project page that I mentioned earlier at cadth.ca/dialysis. We will be updating this page with more information related to our knowledge mobilization work, and we will include a copy of this webinar today. So I invite you to visit the page when you're looking for relevant information. On this page currently, you will also find a review that CADTH has completed on dialysis issues related to specifically to Indigenous patients. So with all this in mind, we are hoping that this webinar is only one way that we can connect for supporting home-based dialysis in your area. And we look forward to hearing more about the context, the successes, and challenges for home dialysis in Saskatchewan. And with that, I'm going to pass it on to Carmen.
Good afternoon, everybody. Next slide. Probably a couple slides. There we go. Okay, so the dialysis options available in Saskatchewan are peritoneal, which is home-based, obviously, and we just refer to it as PD. There are two kinds of PD. There's manual, which is a more simple, basic option of it, where you don't use a machine, you just use some bags to connect up to, and it's kind of fit in with the person's day, however best they can do it. Then there's automated PD, or it might be called CCPD, continuous cycling PD, and that's with a machine that is called a cycler, which is very easily transportable to anywhere someone might need to go. We have hemodialysis, and in that we offer home hemo and hospital or clinic-based. So there would be in-center at St. Paul's Hospital, or any other major center, also in Regina. And there are satellite units, which are at usually smaller centers, smaller cities that make it easy for people to travel to. It's an option that's much closer to home, so sometimes it's just about as good as home dialysis or a transplant in some people's opinion. And we may have things like community units as well. Here in Saskatoon, we've got, it's kind of like a satellite unit right across the street from our hospital, but a very large dialysis unit called the Community Renal Health Center. And other locations, in fact, in this province are at the Regional Psychiatric Center, which is a maximum security prison here in Saskatchewan, but we had at one time been dialyzing a lot of inmates that needed guards to accompany them here, and just a lot easier and more cost effective to have it within their own center, and they may have 4 or 5 patients at any one time. To access any of these treatment options in Saskatchewan, the patient must be under a nephrologist's care from either the Saskatoon or Regina program, and that nephrologist would work with the patient and the patient's family or support people and other nephrology team members to ensure the patient has made the appropriate choice for them. Treatment can then start when the time comes, or if. Sometimes it may never come. The person may pass away of other causes, or it may just stabilize. But for the most part, we try to prolong the time it takes for them to need dialysis or any other treatment, and keep them as healthy as possible so that dialysis is a very smooth transition. So I would say in Saskatchewan there would be something to suit just about anyone here, regardless of their location. We don't have assisted PD, but we're working on some other options for peritoneal dialysis out in communities. But it means sometimes home therapies aren't always the best option for people in our province because of water supply or water issues or water quality, maybe storage space at home or supports in the community, but there would be something that the person can do, even if we have to arrange transportation for them to come into a major center. Next slide, please. So a little bit more detail about the peritoneal dialysis here in Saskatchewan. There is initial assessment made by a dialysis access clinician. So our programs have specially trained registered nurses that are experts in assisting patients with choosing a dialysis access and working with surgeons and radiology to get these accesses placed. So for PD, they would need a surgical placement of a dialysis catheter into their abdomen, as long as they're medically stable and well enough to do it, and there are no contraindications such as previous history of surgeries or some other medical conditions. The person gets about 5 days of training with a home dialysis patient educator, so that would be at the main PD unit, and if they're done a little bit earlier and they're comfortable and confident to go home, they could be done sooner. And honestly, if it takes us a couple weeks to do it and get them safe and comfortable to go home, we'll just do whatever it takes. The automated PD, which is the machine, the cycler, is done every night for about 8 to 9 hours a night usually, and the manual PD exchanges are done from 1 to 4 times per day, and it takes about 20 to 30 minutes per exchange. So that may be a plus for some people when you consider the time it takes to do a 4-hour hemodialysis treatment, and it may also be a deterrent for some as well, because that can add up to a couple hours out of their day. Follow-up visits for PD patients are needed to be seen by the interdisciplinary team, and that would be a team of a pharmacist, dietitian, social worker, nephrologist, and our PD RNs, and that happens at the training centers every 2 to 3 months. It depends on the patient's needs and what the nephrologist feels is best. And our home dialysis nurses are on call for our patients, so there's someone to assist them 24/7 usually. Supplies can be delivered to any community and location in Saskatchewan as long as the patient is medically able to have the catheter inserted and the dialysis process proves to work. This could be a great option for anyone with appropriate storage space, such as a room where they can keep all the supplies or enough square footage, a room that has the proper temperatures, it can't be, freezing the solutions, and cleanliness as well, which can be an issue for a lot of people in remote communities. And then those people can just do it themselves or have a caregiver trained sometimes to do it for them. So sometimes we may have patients come to our programs where their spouse or a child that lives with them full-time might actually be trained to do it if the person cannot physically do it themselves. Next slide, please. How many people do we have using PD in Saskatchewan? Our total number province-wide, that's urban and rural, is 210 patients. And our numbers have grown quite significantly in the past few years, which both our programs are very proud of. Saskatoon has about 135 patients, and Regina about 75. And you can see below that what the average ages are of these patients, and that a good portion of them in Saskatoon at least have diabetes. So, diabetes is the #1 cause of kidney disease around the world, and it's really great if a person with diabetes can have this home dialysis option that doesn't involve surgery or use of their blood vessels, which sometimes can be very poor in the diabetic. Next slide, please. Now a little bit about home hemo in Saskatchewan. So again, the patient, just like with PD, gets assessed by a dialysis access nurse clinician. So the specialist in assessing the patients and helping them make the right decision, booking all procedures, and helping with to get surgeries arranged. So we would want that person to have a vascular access, which means, of course, using the blood vessels, and that would be a fistula, a graft, or an internal jugular catheter. We always want people to have the fistulas if they can, because it's using their own normal blood vessels in their body, and the vascular surgeons would sew them together in such a way that we would have a really good blood vessel to insert very large bore steel needles into for many, many years, hopefully. If that's not possible, we go to the graft or the catheter if needed. So minimum 6 weeks training by a home hemodialysis patient educator. And again, maybe some of our patients have been confident and safe and ready to go by the 5-week mark. Maybe some have needed 10 weeks. We certainly don't judge based on their progress. As long as they're making progress and they have that desire to do it, we'll do whatever it takes to get them home safely so they can have that independence. So they will be home when their electrical and plumbing renovations are completed. The patient passes all their quizzes and test scenarios, because we make them practice any kind of a little problem scenario they could encounter while they're under our nurses' care here in the major centers. The treatments are usually about 8 hours per night while sleeping, 3 to 4 hours during the day, most days of the week. And, it can be tailored to suit the person as needed as best. But, best case would be about 5 or 6 nights a week while they're asleep. Follow-up clinic visits, again, with the interdisciplinary team, our pharmacist, dietitian, social worker, nephrologist, nursing staff, every 1 to 3 months. And they do get a home visit every 6 months. So our training nurses and our social worker often go out and travel to their home community to make sure everything's going good there, because you can't always assess the state of affairs just by telephone or a few questions in person. Going home and seeing them in their environment and seeing what might be going right or wrong is the way to know. And those home hemodialysis nurses are on call too, like they work with the peritoneal. So home hemo would be similar to peritoneal in ways that supplies can be delivered to any community and location in our province, and as long as that patient meets the minimum criteria, passes their initial home assessment, completes their training, it could be done anywhere in this province. That water isn't an issue. And then water does become an issue in a lot of remote communities where there can be a lot of bacteria or things in the water, and it just simply isn't safe to drink. And there's always a boil water advisory or flooding, things like that that make our water quality questionable. Next slide, please. Numbers of home hemo patients in Saskatchewan. So total for the whole province is 31 at this time. And again, it is growing since we first started a few years back. Not as great a quantity as PD, but there's a lot more to it, and there would be a few more barriers maybe to this kind of dialysis being successful than PD. But in Saskatoon, we've got 20 patients. Regina, we have 11. And again, you can see the percentages of people that might be First Nations, and often those could be rural patients or more, on reserve. They could be if they have good quality water. And Regina has quite a few more diabetes patients than we have here in Saskatoon. Next slide, please. What makes home dialysis successful in Saskatchewan? Well, our provincial target that we have now is to strive for 30% of all dialysis patients in our entire province on a home-based therapy, and we're currently at 28%, and probably won't be long before we do meet the 30. We have a lot of support from our nephrologists and all of our staff, especially people that have been around and working the dialysis units for a long time. There is such a greater amount of independence and improved quality of life, as we heard with the previous speakers. We've got a lot of dedicated home dialysis professionals, and patients, they spread the word to each other. I mean, the ones that have been successful and will admit that it's changed their life, they can't say enough good things about it, and they're the first to offer their advice and encouragement to others who may want to choose a home dialysis therapy. Now, there have been some that try these therapies and they quit. It might not be for them. Sometimes there is a medical reason where they're not stable enough and they have to simply go on in-center hemo. But even though it can be exhausting and a lot of work to maintain the equipment and get your supplies and store things and recycle things that are garbage and waste after, they wouldn't have it any other way. Just the independence, the reduced need for travel, and having somewhat of a normal life again, taking less medications, eating and drinking more of what they want, and just feeling a lot better for themselves and for their families. And I mean, you can't deny that that would be a much better way to live, wouldn't it? Next slide, please. Some of our barriers, and these will be some of the same things that we have heard again in the previous slides with previous speakers, but sometimes there are extra costs that are not covered by Sask Health or FNIB, such as water, electrical power, and for some people, yeah, maybe another $200 or $300 a month. It's not a big deal, but for many people in our province, that is just simply, they can't possibly pay it, so it's out of the question for them, and it's very sad when that happens. Motivation, and some people, they simply want to be taken care of. They don't want to be bothered, and they don't even want to look at the benefits down the road. And it's a patient's choice. Housing, some people don't have a home, right? Some people are moving from family to family, house to house, or they're renting periodically in one place and kicked out soon to try to find another place to live. So if you're looking at home hemodialysis, there could be a lot of landlords that don't want someone to have this equipment brought in. They wouldn't want those renovations done, wouldn't allow for it. There's lack of space often if you have crowded homes where you've got a few families living in one home. That can be quite a barrier. Education to make informed choices, and our programs are doing a lot of work to try to figure out how we can improve our education and give more culturally appropriate education to our First Nations and Métis population and other immigrants as well. Poor water quality, inadequate water, I talked about that, and along with there being water that might have a lot of bugs in it to make you sick in some of the northern communities, the remote communities. There's other communities more in central Saskatchewan that have a lot of minerals in the water that it can make it difficult, and you might need special reverse osmosis equipment. There's fear, you know, everybody's afraid of the unknown. A lot of people have needle phobias. Some people, they have to be pretty well sedated just to have their first hemodialysis treatment. So to think that they might have to do it themselves one day, that's quite a barrier to overcome for some. But, you know, we've had some that have done it, and they couldn't be more proud of their accomplishments. Travel sometimes from some very remote areas, you know, it can be that a road could be washed out and you can't get supplies to the person. That has happened on occasion. Lack of supports at home, and some people are afraid that they might need someone. Maybe if they're a single bachelor farmer out in rural Saskatchewan, they think they need someone around to help them with the dialysis, or, you know, if a complication happened, what if I died? How would that go? And that can be very scary for people, and a reason to just stay on conventional or in-center dialysis. Language barriers too. We have a lot of people that might require a translator, and sometimes our teaching resources aren't always the best. They don't quite get those messages across. And lastly, things like addiction, psychosocial conditions, you know, mental illness, and if someone is not stable in that regard, that's quite a responsibility for them to take on. If they're battling with illness or addiction of some other sort, how are they going to be stable enough to do their own dialysis and do it safely and come to all their appointments and things like that. Next slide. So that's about all that I had to say about dialysis in Saskatchewan. Again, we're very proud of all of our growth in our home dialysis programs and the experiences for the patients. So for more information, feel free to contact either of our managers in Saskatoon and Regina programs, Tiffany Blair for Saskatoon, and her telephone number is there, and Edward LeBlanc as well in Regina. Thank you.
Great. Thank you very much, thank you very much, Carmen, for your presentation to all our presenters today. I'd welcome anyone, if you have any questions or comments that you'd like to make on the information that you've just heard over the past hour, please put them into the chat box on the GoToMeeting screen, and we will relay your message or your comment or answer any questions that you might have. Next slide, please. So as we mentioned throughout this presentation, if you're looking for more information on this project or any other work that CADTH has done related to dialysis and renal health, you can go to cadth.ca/dialysis for our main landing page. Feel free to contact myself, Kathleen Kulyk, if you have any questions for CADTH related to any of the information that you just heard. My contact information is available. And of course, you can contact Tiffany or Edward if you have any questions specific to the Saskatchewan program. So thank you very much for joining us today. We'll leave the chat box open for a couple of minutes in case you have any questions for us to answer. We do have a comment here in the box, the chat box, so I'll just relay it to the rest of you. There are downsides of pushing patients to do home therapy, especially if the slant is that it is economic dictating choice. If clinical outcomes are similar, which seem to be, patients should be allowed to do what suits them. This evidence might be used by providers to set targets and performance measures to increase home therapy numbers because it is cheaper for them. Unintended consequences. And this is why it was so important when we did this review to include a section on patient preferences and perspectives, and as well as a section on implementation, because it's not always a clear-cut decision, and a decision should never be made simply on the evidence. There's many other components that go into making policy decisions and clinical decisions. And so I hope that you found some of the information that we provided on patient perspective useful, and we hope to use that information to help better support implementation and policy decisions down the road. as we all know in healthcare, there's never, it's never an easy decision. There's many facets that have to be considered.
Kathleen, we have one question for Carmen.
Okay, go ahead.
It is, what else are you looking for to improve home dialysis in Saskatchewan? And if there is anything, what would be the first thing you would do?
Well, we are looking at improving some of our teaching and classes offered here in Saskatoon on the options, making them more appropriate for some of the populations that we serve, maybe taking it out to communities instead of having people come here. And we have been doing some work where we discuss this in kind of great depth with First Nations and Métis populations to kind of find out firsthand from them what their real fears are and thoughts are, and if it can be made more appealing. People don't want to be driving, and everybody seems to want a dialysis unit in their community or very close to it, but we try to promote that. If we can't prevent it, maybe we could get you on home dialysis, and that would be better for you. You would live longer, you will have less complications, you'll feel better, you'll be able to take less medicine and eat more of what you want. And, for me, I say a plus of that is that it is cheaper, but it's just better, right? I mean, we have to promote that it's better for the person's health long term.
Great, thanks, Carmen. We do have another question on here, perhaps might be for Gino. When mentioning cost analysis of home therapies versus in-center hemodialysis, was cost of hospitalization and transport related to home therapies included in the analysis? Similar to Saskatchewan, many patients in Manitoba have to be sent down for assessments of peritonitis, etc. This has the potential for unstated cost. Thoughts? And I'm wondering, Gino, if you could comment on that.
Sure. So I will first state that I was not entirely involved with the economic evaluation, but having just gone through the report, it does appear that they did consider all these costs, and I know that several sensitivity analyses were conducted. So for these types of specifics, I do suggest having a closer look at our report to see just exactly what was done with all these analyses. But several sensitivity analyses and costing analyses were done in the report, so please do have a look at that.
Great, thanks, Gino. We have one other comment here, too, from Manitoba. It says, Manitoba has in 2015 introduced a utility reimbursement program for home hemodialysis. Another comment we received. So it looks like we've come to the end of our hour. I want to thank everyone very much for joining us today. This webinar was recorded, so if you would like to share this with any of your colleagues, please feel free to do so, and please contact us if you have any questions. Thank you and enjoy the rest of your day.